Just bear with me. It's just, yep, it's all done. Okay. Thank you everyone for joining today. And it gives me immense pleasure to introduce Marco, who's going to talk to you about navigating uncertainty and exploring causation. This is the FIMO Research Committee webinar. This is the fourth in series of the FIMO Research Committee webinars for this year. And it all started as a research committee when we started working on different issues around research. So we thought it, rather than working on research projects or talking about research, it would be useful to organize organize events which provide people with an ability to learn subjects, explore issues, and therefore develop networks and have mentorship opportunities. And this is where these seminars come in. We do it once every 8 to 12 weeks on a topic which hopefully would be relevant to Sigma members, nurse researchers, PhD students, and others who are doing it. My name is Parveen, and I'm based at the University of Sheffield and Doncaster and Bassetlaw Teaching Hospitals. And here I am as the chair of the FIMO Research Committee. So today's webinar will be delivered by Professor Marco Tomiato. Marco brings a wealth of expertise from his research in clinical learning environment, mentorship about organizational transition in nursing, and his interdisciplinary approach, blending work and organizational psychology with nursing science, has led to substantial contributions in nursing education and management decisions. His latest research covers areas such as VR technology adoption and vaccination hesitancy, making his insights invaluable for advancing nursery research and practice. Marco is based at University of Northumbria, and today he will be talking about the philosophical and methodological underpinnings of causation in nursing research. So without further delay, I will leave it to Marco to add anything else that I have missed about him and to take off with the talk. If you have any questions, please do keep writing onto the chat or keep a note for your with you. And what we could do is, once the presentation has ended, which will be about 40 to 45 minutes, we can then have a discussion about the questions and take it from there. And you could also please talk to each other and do introduce yourself into the chat box. That would also be great. So over to you, Marco. Thank you for doing it.
Thank you, Praveen, and thank you everyone for joining us today, just a few days before Christmas. So welcome. And today I'm very pleased to share with you a journey through a concept of causation and to reflect with you and reflect together on its implication in nursing research. Reflecting on the complexity of nursing in clinical practice, education, and research is a journey we share all together in our careers. So feel free to share your thoughts anytime during this presentation. We have also other remarkable colleagues connected, so please, anytime, please interrupt me and share your thoughts and reflections. We will start this journey with some philosophical consideration, and then we will reflect on some methodological criteria and statistical tools we can use to explore causation. Causation is a fundamental concept in understanding the complexity of reality and especially of healthcare and nursing. As researchers and healthcare practitioners, we are committed to uncover these causal mechanisms underlying the phenomena we observe in our everyday practice. We all think every day about causation. For example, when we identify the early signs of patients' clinical deterioration, when we prevent pressure ulcers, falls, or malnutrition in clinical practice, or if we think about the predictors of academic success, if we think about educational research and nursing students, or the organizational factors improving nurses' retention and job satisfaction. It's all about prediction and causation. All these areas tell us something about the relevance of causality in our everyday practice as researchers, clinical nurses, nurse leaders. However, causation in nursing and healthcare is something embedded in the complexity of the healthcare settings. And this complexity is our major challenge to address. Now, I would like to start with some philosophical considerations. And David Hume is an important philosopher when we think about causation. He was an empirist, and he argued that we do not perceive causation directly. It's not out there in nature. We can infer causation from patterns of events. So we can empirically see some patterns and infer about causation. For example, when we see a fire, we don't directly observe the water extinguishing the fire through a hidden causal force. We cannot see this causal force. Instead, we observe a consistent pattern. When water is applied to fire, the fire is extinguished. So based on this consistent pattern, we infer that the water causes the fire to be extinguished. So is our interpretation of a consistent pattern. And we will see later on that there are some criteria, and consistency is one of these criteria to explore causation. Of course, things are much more complicated than this. When we search for patterns within complex systems, adapting to many different elements, things get much more uncertain and difficult. And this is what happens in nursing and healthcare. This inference is influenced by uncertainty. There might be many different explanations, and not all possible explanations are equally plausible, probable. Everything is possible, but some options, some explanations are more probable than others. And our goal in research is to reduce this uncertainty by striving for the most robust explanations. I'm sure we are all familiar with the inductive and deductive process. As we know, induction involves generalizing from specific events. But not every specific observation can be reliably generalized to a broader category. And we must be cautious in our inferences. We have some, again, methodological tools. We will see study design is key. And we have also some statistical tools we can adopt to provide valid and reliable inferences. And again, I'm pretty sure we are all familiar with the theoretical levels in nursing research. Our approach to reasoning can be classified, as we know, as inductive and deductive, but we will see soon that there's also meta-induction we can adopt. We all know that inductive reasoning moves from specific events to generalizations, and deductive reasoning moves from general principles to specifics. Each approach, of course, has its strengths and limitations. And in nursing, we are all familiar, for example, with the different theoretical levels. We know that micro and middle range theories are extremely useful to set our research hypotheses, and they are easily measurable and close to reality. These theories can be used to predict some patterns in our everyday life. For example, if we think about the self-care theory, but also real phenomena can be easily observed and measured to validate those theories. When we identify a specific phenomenon, for example, self-care, and a specific outcome, for example, the reduction in the hospital readmission rate, for example, and we will see also this in more detail soon. As I mentioned before, there's also meta-induction, and I'm pretty sure that in our everyday life, we use quite often meta-induction. Meta-induction is a pragmatic approach to reasoning. We don't need all the time to observe the phenomena through an inductive process and then make our generalizations. Meta-induction draws from a broad set of precedents rather than isolated cases or observations. We can already count on a considerable body of empirical and theoretical knowledge, and we don't need to measure again and again different phenomena to validate a theory or to find a pattern. This approach reflects on the practical nature of scientific inquiry, where patterns and established theories are used to inform future predictions. For example, we already know that a nurse-to-patient ratio affects patient mortality, and we can test, expand this pattern, and validate it by observing new phenomena, and hopefully also, of course, by taking action to improve patient safety and patients' outcomes. Are you with me at the moment? Is everything clear? Any questions? Okay. I will continue now, and I'll go back to Hume's insights, and we can see how they remain relevant in contemporary science. Our assumptions about causality are shaped by our previous assumptions and previous knowledge, of course. By acknowledging that all options are possible but not equally probable, we position ourselves to make better decisions and predictions, of course. We have also several tools. Sorry, I'm trying to follow this. There's a new, okay, admit. In our scientific and clinical reasoning, we have some tools to identify the most suitable hypothesis. For example, the Occam razors is a useful tool in guiding our choices. Let's have a look at it. Can you see my next slide about Occam razor? Okay. So, Occam razor is a principle that suggests selecting the simplest hypothesis, linking several phenomena. This principle postulates that entities must not be multiplied beyond necessity. It is a parsimony, a simplicity principle, guiding us to prefer the simpler explanations, especially in causal inference. And in navigating through the complexity of nursing and healthcare phenomena, most of the time the simpler explanation, linking as many phenomena as possible, is also the most valid and reliable. For example, I don't know your clinical background, but I'm a coronary care unit nurse by background, and well, I manage quite a lot of patients with heart attack or myocardial infarctions in my career, in my clinical career. So thinking about cardiology, when we make a clinical assessment of a person with chest pain, for example, an elevated ST segment, and altered troponin levels, we immediately think about a myocardial infarction. This is more plausible, and it's simpler to think that these three phenomena are linked to one only explanation, in this case, a myocardial infarction, rather than thinking about an isolated intercostal pain, an electrolyte imbalance, or rhabdomyolysis. So it's the simplest explanation, the one linking the three different phenomena to a single explanation, which is the most relevant and maybe also the right explanation, rather than having three different explanations to explain each single phenomenon. And this is the Occam razor in action. I'm pretty sure that in your everyday practice as researchers, clinical practitioners, or nurse leaders, you use the Occam razors almost every day in trimming your hypothesis and explanation of reality. When applied to causal inference, Occam razors leads us to trim unnecessary hypotheses. And again, simpler explanations often have a greater explanatory power and are easier to test. In face of multiple possible causes, this approach helps us to focus on the most plausible explanation, and plausibility is another important criterion to consider when thinking about causality. We will see this later on. I would like to stay with you on this philosophical part of this presentation. And I really love this author. I don't know if you know it, is Robert Pirsig. And he postulated in his novel, actually, is a novel, is not a non-fiction book, is The Zen and the Art of Motorcycle Maintenance. This book has fantastic insights into scientific reasoning and rationality and so on. So Robert Pirsig said that a given phenomenon could find a never-ending number of rational explanations. So rational explanations for a phenomenon are potentially endless. Occam razor is one tool we can adopt in our reasoning to trim our hypotheses and make our decisions. There are many, many possible explanations, but we should focus on the most probable explanations. Again, take a minute to read this story. It's from a psychologist. Have you read it? Okay, I hope so. So, this story of the man searching for his keys under a lamppost because the light is better here illustrates a common bias in scientific research. When we focus on areas where evidence is easier to obtain rather than where the actual problem lies, is a bias in scientific research. We should move our reasoning and methodological tools, our light, where the actual problem is. And for example, another tool we can use is abductive reasoning, which we will explore very soon in the next slide. This is another tool we should consider when thinking about causality and scientific reasoning. This is the process of abduction. Abduction involves three key steps: observing phenomena, generating hypotheses, and selecting the best explanation. Can sound a bit redundant because this is basically the scientific method. But I would focus with you on the criteria for the selection of the best explanation. These criteria are simplicity, and again, it resonates with the Occam razor. Coherence, the coherence, for example, with previous evidence, to previous evidence and our previous theoretical knowledge about a given phenomenon. Comprehensiveness and testability. And again, is about reflecting the level of our theories and our capacity to measure the phenomena we are interested in. So, simplicity, coherence, comprehensiveness, and testability. And until now, we have explored some aspect of philosophical and scientific thinking about causation. So basically, through observation, experimentation, analysis, researchers aim to identify these causal relationships. The rigorous structure of scientific methods enables us to test and refine our understanding of causality. But now we also need some methodological criteria to establish causation. And in healthcare, and basically this is from epidemiology and medicine, Bradford-Hill's criteria are another powerful tool that offers a systematic approach to evaluating causation and exploring reality. These criteria play an important role in strengthening causation. The Bradford-Hill's criteria were developed in epidemiology, as I mentioned before, and in medicine, but they provide useful methodological insights into many different disciplines and nursing as well. So let's dive into these criteria. The first one is the strength of association. The stronger the association between the exposure and outcome, the more likely this relationship association is to be causal. For example, as we mentioned before, nurse-to-patient ratio is associated, linked to patient mortality. We know this. There's a body of evidence about this, replicated quite strongly along many years. And we know that there's a strong association between the exposure, nurse-to-patient ratio, and an outcome, patient mortality. And we can explore the strength of association of many other different, for example, also psychological variables. Leadership style and nurses' retention, for example, is another example. The second criterion is consistency. The association should be consistently observed in different population and settings. Again, this is important in nursing research. What I see in my everyday practice as a nurse researcher, there are many cross-sectional studies based on a single setting. This second criterion helps us to focus on the relevance of multicentric research design and of course also replicating our studies in different settings and populations to strengthen the causal relationship of the exposure and the outcome we observed every day. Another important criterion is specificity. A specific exposure should lead to a specific outcome. For example, the exposure to certain leadership styles, as I mentioned before, in healthcare, and job satisfaction and nursing retention. We should also reflect about this on the validity and reliability of the measures we adopt in nursing research, as we often explore psychosocial and behavioral variables with the psychometric scales. But this is another story. It's about the reliability and validity of the measures we adopt in research. But this is crucial to establish the link between a specific exposure and a specific outcome. Temporality. Temporality is key also to establish causation. For example, in nursing research, we adopt often cross-sectional designs, which is fine, but longitudinal research is another important element to establish strongly causation in between the exposure and the outcome. So temporality. And I would like to reflect with you on the relevance of longitudinal research in nursing. Well, as I mentioned at the early beginning of the presentation of the Bradford-Hills criteria, these criteria are about epidemiology and medicine, basically. So Bradford mentioned about the biological gradient. But the key take-home message here is a dose-responsive relationship that is important to strengthen the evidence for causation. Of course, this is focused on medicine, but in nursing research, we also consider a dose-response relationship. Again, if we think about the exposure to a low nurse-to-patient ratio and patient mortality, it's about a dose-response relationship. How many nurses, how many patients are allocated to one nurse? And we know this is dose responsive if we think about patient safety and patient mortality. Or the exposure to workplace incivility and job satisfaction, or to a good clinical learning environment and students' academic success. We can see in our everyday practice this dose-response relationship, and this is another important criterion to consider when establishing a causal relationship between an exposure and an outcome. As I mentioned in our philosophical reflection earlier, plausibility is also important. It's not only about the biological plausibility, it's about the theoretical plausibility. For example, if we think about enhancing self-care competencies in our patients and the prevention of hospital readmission, or promoting patient empowerment and well-being, this is a theoretical plausibility, which is important when we think about causation. And again, this other criterion resonates a lot with the previous one. The association should be consistent with known facts and not contradict established knowledge. This is a bit tricky. This is, of course, about the consistency with previous evidence. However, this is also controversial, as I said before, because we also need sometimes to contradict or at least to expand previous evidence in order to provide new knowledge. And we will see later on an example of this. Another important criterion is experiment. Evidence from experimental studies, such as randomized controlled trials, are important to establish causation. Again, in nursing research, I think we should plan and think about RCTs a bit more to strengthen the solidity of our research and, of course, the case to establish the case for causation. And then the last criterion is analogy. And this is about, again, theoretical thinking, similarities with already known causal relationships, supporting the inference for causation. We can use all, of course, theoretical thinking, but also some statistical tools. And we will dive into this very soon. But here, the take-home message is that we must recognize that causation is mostly embedded in the design of studies. Proper experimental design, longitudinal studies, and other research methodologies are essential for making strong causal inferences. This understanding is fundamental to advancing nursing research. And of course, in our box, there are also many statistical approaches we may use to suggest and to establish possible causal links. However, we must be very aware and mindful that statistical tools do not replace a robust study design. We can use structural equation modeling if we think about quantitative research, regression models, unsupervised machine learning clustering approaches. But again, they are tools and they cannot replace a good study design and theoretical understanding of our phenomena. So let's consider now some statistical perspectives, some statistical use we might employ to explore causation, even with cross-sectional design. But of course, a cross-sectional design should be considered as a limitation. In this example, you can see a basic structural equation model where the leadership style of the ward manager influences the newcomer nurse's competence acquisition in the organizational entry. You can see here a few statistics. They are fit indexes of the model, which are quite good. But let's have a look at this model. Here you can see that the direction of the arrow is changed. And we see also that the statistical fit indexes are exactly the same. Now, I don't want to go into the technicalities of this, but here the take-home message is that from a statistical point of view, both models are valid, but theoretically speaking, they are very different. So we should look again at our philosophical thinking and scientific reasoning. We should look at the simplest explanation if we think about the Occam razor. The most theoretically consistent explanation if we think about the Bradford-Hills criteria. And this theoretical consistency should be based on our previous knowledge of theories and empirical patterns, if we think about meta-inductions, for example. From a theoretical point of view, it makes more sense that the leadership style of the work manager affects the acquisition of the new competencies required in the organizational settings by the newcomer. Now, I would like to share with you another example. Again, is about organizational socialization. Let's start here from a theory. So this is a theory called Contents of Organizational Socialization. And this theoretical approach outlines 4 key dimensions that influence how individuals integrate into a new organization. These dimensions are, at the early beginning after organizational entry, there's training, and these dimensions focuses on the learning process that new employees undergo to acquire the skills, knowledge, and competences required for their roles. The second factor is understanding, and is about the understanding of the formal and informal rules within the organizational setting. For example, protocols and guidelines, but also the unwritten rules within the organizational settings. Sorry. The third factor is co-worker support, which is the support from our colleagues, helping us to adjust into the organizational setting. And then future prospects. This dimension relates to an employee's perception of their long-term career opportunities within the organization. So now let's see from the empirical point of view if the phenomena we observe out there in nursing are consistent with this theoretical framework. This is a regression model, and this theory was tested in nursing for the first time during my doctoral studies a few years ago, actually. So this was a cross-sectional design with several regression and structural regression models. This, in particular, this regression model stratified the sample into newcomer nurses within 6 months of organizational entry, between 7 and 12 months, and after 1 year. The dependent variable, so the outcome variable, was turnover intention. So we have an exposure, the exposure to several components of organizational socialization, and an outcome, turnover intention. We observed that in the first 6 months, the most important factors for reducing turnover intention were the acquisition of the required competencies and the understanding of the formal rules within the organizational setting. For example, protocols and guidelines. In the second semester, after organizational entry, the most important factors were co-worker support, so being part of the team and feeling supported by the team, and career development perspective. But after 1 year, the only relevant factor to decrease turnover intention was the career development perspectives in the organization. So, going back to the theory, this empirical testing validated the theory. So, the theory correctly predicted the empirical pattern and the observed phenomena confirmed the theory. So we can say that there's a causal relationship, connection between organizational socialization components and turnover intention, of course, with the limitation of a cross-sectional study. But let's go back to the first 6 months, because there's something different from the theory. I don't know if you noticed, but let's have a look more closely to the model. As you can see here, the factor understanding was split into formal and informal understanding. This is about the psychometric testing of this tool. We identified 2 factors about understanding, not only one. So we split the formal and informal understanding. And we all know that in each organization, there are written and unwritten rules. In this sample, informal understanding significantly increased turnover intention in the first 6 months. Again, there are many different explanations about this. We should dig deeper about this to understand why. Perhaps the unwritten rules clashed with the written ones. Or there may be many, many other possible explanations. Again, we should explore, test, find a theoretical support about this, test and retest in different populations and see if this is true. The point is that empirical testing here expanded the theory with new insights into the organizational socialization process of newcomer nurses. And we can see how expanding the scope of our reasoning beyond the comfort zone of the lamppost, if you remember the metaphor about the man searching for his keys. If we expand our reasoning beyond this comfort zone, while keeping things simple, coherent, comprehensive, and testable, we can explore new insights in this way and hopefully also new perspectives about causation. Of course, now, as I mentioned before, this new model should be tested with a longitudinal design because organizational socialization is a longitudinal process. And also, it would be good to explore this in different organizational settings to strengthen this causation and these findings. So, in summary, going through to the conclusion of this presentation, statistical tools, the third pillar of causation we just explored, are also useful to explore causation. But we should always remember they do not replace a proper study design, scientific and philosophical reasoning. So, to conclude, navigating uncertainty and the complexity of causation in healthcare settings and in nursing research requires a balance of theoretical understanding, empirical evidence, and methodological rigor. By embracing this complexity and remaining open to revising our hypotheses, we can advance our understanding of causation in healthcare and nursing research. Thank you, everyone, for your attention.
Thank you so much. That's been excellent and really useful. Any questions, any comments, anyone? There are lots of clappings.
Thank you.
I don't know how you do that clapping thing. I can't see it here, but
You do, if you click on the react thing, I think
anyway.
it should give
Oh, I
you
see
different
it now. I
options.
see it now. Yes, yes. Okay, I'll clap like that though. Yes.
Thank you, Rosa.
Yeah. Marco, can I ask you, you mentioned right at the beginning the issue of complexity. Um, I mean, that seems to me like the biggest confounding factor, especially in what we do as nurses in attributing effect from a cause, sorry, cause from effect, because we do things that are very complicated and quite dirty in a way, which I mean, you might be doing a dressing or you might be doing a psychosocial interaction, but there are so many other variables that it's very, very difficult to control for. So I just wondered where this sat within the whole area of complex interventions and if you thought that was actually being used properly or giving us any new insights into cause and effect.
Yes, yes. Thank you. This is extremely relevant. Well, for example, we have the guidelines to develop complex interventions in healthcare, and this is an important aspect to consider when implementing complex interventions. And well, it's also important to reflect about what is complicated and what is complex. I'm Italian by background, so I look at the ultimate, at the meaning of words and the origin, the roots of the words we use. For example, complicated is from cum plica, is about folding things. And I like to use this metaphor. For example, I take just this piece of paper. Something complicated is something we can fold and unfold. So basically, this is complicated, but we can explica from cum plica, explica. So we can explain then this piece of paper. Sorry, is the image is not so. But what is complex? We cannot reduce what is complex in something that is complicated because there are so many factors and aspects interacting in this complexity. And I think this is the beauty and the challenge of nursing research. And it's not that easy, it's not so easy to address this complexity. And I think that this is the reason why it's so important to replicate our studies also in different settings and over time.
Yeah, yeah.
So, thank you. I don't know if I addressed or expanded the reflection you introduced. Thank you.
Lisette?
Hi, Marco. Yeah, thank you for the presentation. So I found it quite interesting, and then probably link it to what Roger was kind of perhaps alluding to is, the complexities when we study social phenomena and how, qualitative. So, you provide several criteria, and necessarily I'm a qualitative researcher, so I was wondering, like an interesting conversation when we talk about causality in using qualitative methods and the fact that they are very difficult to replicate because of its nature. So I don't know if you have any thoughts in kind of social research and qualitative methods. So thank you, very interesting, a lot of things to think about.
Well, thank you for this reflection and this question as well. I think it's very important. I'm a quantitative researcher by background, but I must acknowledge that often quantitative research can provide insights about the causality and the association, correlation between events, hopefully prediction. But quantitative research often is not so good in explaining why. So this is this is the reason why I think mixed method approaches and designs are key, especially in nursing research, to disclose the complexity of our phenomena and understanding these patterns. And of course, by replicating also qualitative research in different settings, we can understand if this is, for example, thinking about psychosocial and behavioral aspects, if there's a pattern in different contexts. And so qualitative research, I think, is key to further understand these links, causational links. Thank you.
Thank you. Anybody else? Just last question or comment? Okay, well, it's nearly 1 o'clock. So thank you everybody for joining us. I'm very grateful, and thank you, Marco, for doing the session. I'm just going to stop putting the live stream.